Welcome back, guys. So, today we'll be talking about the use of tongue flap for reconstruction of recurrent palatal fistula. So, say this is our oral cavity, this is the tongue, and this is the palatal fistula. So, what are the indications of tongue flap for the palatal fistula? So the tongue flap is not commonly used for this coverage of the palatal fistula. It is used when the local tissue is not available. Local tissue flap is not available, or the local tissue vascularity is compromised because of the multiple previous procedures. And it is also used where the local, like this tissue is local flap area is scarred, so that so as we are not able to use the local flap cover. It is scarred local tissue. So the tongue flap, we can harvest the tongue flap as anterior based, or it can be posterior based as well. Mostly anterior based is used, and it is anterior based tongue flap is like will mark the flap as shown here, and then we'll lift it and cover the defect. So the blood supply of the flap will come from anterior aspect. So anteriorly based tongue flap is mostly used for anterior palatal defects and for mid palatal defects, and the posterior based flap is used mostly for the posterior based posterior palatal fistula, that is fistula of soft palate. So how do we harvest the flap? So we will freshen up the margins of palatal fistula, and then we have to reconstruct the nasal layer of the palate using the oral mucosa, and after everting it and suturing it over here. So next, what will we do? We will measure the size of this defect, and then we'll mark it, mark the flap here over dorsal aspect of the tongue, and the flap that we are gonna harvest should be greater than that of the original defect, and the diameter, it should not exceed 2/3 width of the tongue, otherwise tongue vascularity will get compromised. So what all layers we have to take in the flap? We have to take mucosa, submucosa, and a thin layer of intrinsic muscles of the tongue. Now we'll raise it, and after raising this flap, the this part of the tongue is closed primarily. It can be closed in single layer, or it can be layered closure as well. So next we will cover this palatal defects with this flap, and this flap is divided after 2 to 3 weeks. So what all precautions we have to take in post-op period? In post-op period, a good oral hygiene has to be maintained. Secondly, the tongue movement should be minimal, so as to avoid dehiscence of the flap. And third, the patient has to be kept on soft diet or on liquid diet. Now, what all can be complications of using this tongue flap for palatal reconstruction? So there can be bleeding in early stages because of manipulation of the flap. There can be respiratory compromise, and upper airway edema can be there. and there can be necrosis of the flap margins. Speech difficulty will obviously be there because tongue movements are not present. And infection can also occur. So after 2 to 3 weeks, we divide the flap and reinsert it on the posterior aspect.